Hello, I'm Lauren Wagner. I'm one of the palliative care attendings at Mount Sinai, and I'll be talking about patient-controlled analgesia pumps, or PCAs, today. I have no disclosures. So overall, the goal is to talk about how to start a PCA and the dosing that we'll start with and without a continuous infusion, titrating doses, and then switching back to a PO regimen. So PCAs overall are programmable pumps that allow for patients to press a button to get pain medication delivery more immediately. You can see what a PCA pump might look like here with the button over here that patients can press, although somewhat comically, this is an epidural PCA with fentanyl. But overall, when we're thinking about PCAs versus IV PRNs and scheduled dosing, there's not great evidence saying that PCAs are definitely better, but the thought behind using them includes giving patients more control over the timing of doses and getting that medication more quickly when pain does start to increase. Also, as we know, there's significant evidence of racial bias in both pain assessment and treatment plans, and this can be a way to try and reduce that as a factor, though it still is dependent on the dosing prescribed by the provider. Also, when people speak a different language from their team, it can also be more challenging to ask for things like pain medication. So this can be another way of trying to lower that barrier when someone's pain levels are high. And then PCAs can also be very helpful for dose finding, particularly when someone's pain is changing. So thinking about the types of patients who are appropriate for PCAs, we think about both acute pain, including postoperative pain, and then chronic pain for cancer patients or non-cancer patients, like people coming in with vaso-occlusive crises. And for PCAs to be effective, the patient also needs to be awake enough and with it enough to be able to press the button, so not people who are delirious or confused. And then when we're thinking about dosing, it's just also important to think about patient factors that put people at higher risk for side effects like respiratory depression. So head injuries, hypovolemia and sepsis, things like sleep apnea and respiratory failure, and then renal and liver dysfunction. So when we're thinking about the actual setup of the PCA, we typically use 3 different medications: morphine, hydromorphone, and fentanyl. And these can be administered by IV, subcutaneously, or via epidural PCA, though I'll be just talking about IV PCAs here, though the concepts broadly apply to all 3. And the typical setup includes a continuous infusion running in the background, a demand dose that is available when the patient presses the button, with a lockout period where they will not be able to receive another dose, even if they press the button. It's typically about 10 minutes. And then a clinician bolus or a cab that is a breakthrough dose, often available around every hour, that nurses can give from the bag per patient request. And then typically in the kind of programming setup, you'll also enter kind of a 1 hour or 4 hour limit of the medication that can be given over that time period between the continuous infusion and the demand dose. So when we're thinking about calculating doses for PCA, one of the first considerations is whether to start a continuous infusion. This would be the most dangerous part of the PCA, since it's an infusion. It's not going to stop if someone gets sedated or apneic. So this is the dosing that we want to be most careful about. For someone who has acute pain, if they have high enough usage that you're going to use it, it's meant to be more of allowing someone to sleep, so they're not having to press the button all the time, even when sleeping. So for acute pain, we're going to try and get the majority of our pain control from the demand dose rather than the continuous infusion. Versus someone with chronic pain and higher requirements, we're using the continuous infusion more similarly to a long-acting medication for more background coverage. So for someone who's opioid naive, their opioid requirements are likely not high enough to justify starting a continuous infusion, so you'd likely just start with a demand dose. Versus someone who's been receiving opioids, to get the continuous infusion, you can take their total daily dose or 24-hour opioid use, and depending on their pain severity, take either 80 to 100% of that, and then divide by 24 to get an hourly rate. And so for someone who has chronic pain, this is looking like getting about 50 to 75% of their expected dose per hour is coming from that continuous infusion. And if you don't have a full 24 hours of data, you can kind of cautiously extrapolate from a 4-hour time period, where you might do the same thing, but rather than divide by 24, you're going to divide by 4 hours. Well, again, we have limited data there, so kind of being extra cautious in that scenario. And if you're worried about side effects, or if someone has renal or liver dysfunction, kind of reducing the dose further to be on the safe side. So for the demand dose, we're thinking essentially the goal of this is to try and hit the minimally effective analgesic concentration, the MEAC, with this dose. So it's not necessarily getting the pain to zero, but it's decreasing it by 50% or around 2 to 3 points on that 10-point scale. And the goal with the lockout period is to give enough time for that medication to start to have an effect. So we're not getting a second dose before the first has even started to work. And we're also having enough time to see side effects that may have come up from that dose. Again, this is often every 10 minutes for morphine and hydromorphone, but it can be lengthened if there's concerns for adverse effects. And for fentanyl, it'll be a little bit shorter, as we'll talk about. And when there's no continuous infusion, the demand dose is very safe because if someone gets a bit too stated with pressing it, then they'll just be a bit too sleepy to press the button again. So very safe. And there's not evidence to say that trying to be extra cautious with underdosing is safer, and you're essentially just going to be resulting in worse pain control. That being said, though, if someone has renal or liver dysfunction, or if they're older, if you're worried about them, then it's worth it to consider decreasing the dose as well. Just considerations to take into consideration. So thinking about starting advanced dosing for someone who's opioid naive, this is much less common for us in palliative care, as we're oftentimes seeing patients on home regimens or who receive several doses of an opioid in the ED or on the floor. But for post-op patients, they might be a group who we anticipate worsening pain, and they might not have been on any opioids prior to the surgery. So these would be kind of the standard starting doses based off of McPherson. So we see morphine 1 milligram, hydromorphone at 0.2 milligrams, fentanyl at 20 micrograms. And so you would kind of start the PCA with a higher loading dose, followed by the demand dose, typically every 10 minutes for morphine and hydromorphone, and then every 8 minutes for fentanyl, since it's faster on and off. So for patients who have received opioids, though, when thinking about getting the demand dose, there's a few different ways to find the dose. And oftentimes it just involves doing many calculations and kind of seeing which one makes the most sense for a patient. So for patients who are going to be started on a continuous infusion, you can just take 50 to 100% of that continuous infusion dose and make that your demand dose, depending on the severity of their pain. So that might look like morphine 2 milligrams per hour with a demand dose of 1 milligram for someone who's having moderate pain, or 2 milligrams per hour with a demand dose of 2 milligrams as well for someone who looks like they're more uncomfortable. For patients who you're not planning to start a continuous infusion for, you might use their home regimen to come up with a demand dose if they're coming into the ED and you don't have a ton of data. So this could look like taking someone's total dose from their long-acting home med, converting it into an IV formulation, and then dividing that by 24 to get an hourly rate. You're kind of essentially calculating what would be a continuous infusion rate, and then having that to get the demand dose. Or depending on their pain level, you could also take their home PRN, which should last them about 4 hours typically, and divide by 4 to get a demand dose. Conversely, for other patients, if you have enough data, if they've gotten doses in the hospital, you could use the minimally effective analgesic concentration to get a demand dose, or go based off of their 24-hour in-hospital usage. And then for finding the dosing of the clinician bolus, the CAB, we're oftentimes using a ratio where the CAB is double the continuous infusion, or if there's not a continuous infusion, double the demand dose. So that often means that the CAB is about 8 to 10% of their daily dose. And so this might look like morphine 2 milligrams an hour with 1 milligram Q10 minutes for demand, with 4 milligrams Q1 hour for a CAB. Or the other kind of ratio where we have hydromorphone 0.2 milligrams an hour, 0.2 milligrams Q10 minutes as needed, and then 0.4 milligrams Q1 hour PRN. And so after you've started the PCA, if pain is actively uncontrolled, we're ideally checking in soon after to make sure that we have good dosing with the demand dose in the CAB. If we found kind of an effective dose for them, then we're ideally checking in within about 12 hours to check for efficacy and for side effects. And then we're also answering any questions from patients that might come up and kind of reinforcing how to use the pump, particularly to ensure that patients know that they have a CAB available and that they can press it every 10 minutes as needed, as this can oftentimes get lost kind of in translation or communication. So common things that come up for patients is people sometimes ask, how do they know if they're actually receiving doses when they press the demand dose button? And oftentimes there's a light or a sound that goes off when people receive this. You also want to make sure that they're not accidentally pressing the call button rather than the demand dose button, and that it's actually reachable. Sometimes, as we know, things can just get tucked away at the top of the bed. So making sure that they actually have access to it. Sometimes people also feel unsure about when they should press. And so we talk about kind of using it when pain is starting to get up to that 50% of 50% level for them. So we're not chasing the pain. And then many patients also have concerns about safety. So we talk about, with demand doses particularly, the risk of overdose being low because people will just fall asleep if the dose is slightly too high. So that's very safe. We also, though, have patients worried that this will kind of increase the risk for addiction, or they have concerns kind of about the stigma of using opioids. So it's just important to kind of address those concerns, and also kind of reinforcing that we're using these meds for their intended purpose. And just of note, for patients who have substance use disorder, it's not a contraindication for PCA. It just means that we might need to be more thoughtful with what we're doing and kind of working with the patient. And then also another patient concern to make sure that we're addressing, is important to reiterate that it needs to be the patient who's pressing the demand dose, not family members. Even if it's with the best intentions, it just is an increased risk for oversedation if family's pressing it even when the patient is asleep. And so when we're actually evaluating the effectiveness of the PCA, we're looking kind of at two components. One part is looking at the actual PCA pump to check our numbers. And so we can see the total 24-hour amount that was used from the continuous infusion, demand doses, and cabs. We also look at the ratio of the demand dose given versus attempted. So if there's a big discrepancy, if there's a lot of attempts and not as many given, this might mean that our pain's not controlled, or it might mean that someone's pressing it for emotional distress, or it might mean that there's just a misunderstanding on how the pump works. We can also look at the timing of when people are pressing, which is just helpful information regarding their pain, thinking about triggers for pain, and also about our future regimen. And then we also check in with the patient as well to get a sense of the amount of pain relief that people are actually getting from the demand dose in the cab, whether that's a number on that 10-point scale, or more like functionality, like, oh, when I press this, it allows me to sit up in bed or engage with PT. We also want to check in if there's any side effects like drowsiness with the doses. And then I think it's important both in real time as we're making changes, but also just in documentation to track the usage over time to make sure that we're not accidentally having significant escalations without knowing why. And it's also just helpful for future providers coming on so they don't have to look at individual notes to kind of get a sense of the overall pattern of someone's pain. And also just important to be kind of continually reevaluating the source of pain. Let's say our dosage or our usage is going up. We want to make sure that we know what we're treating, that we're not accidentally using opioids for a pain that is separate, or a different type of pain, or a new pain that might be best treated with other non-opioid regimens. And also we want to keep in mind things like some patients' illness acuity. So if their clinical status is changing, if they're becoming very sick, it might mean that we need to adjust the regimen in case someone acutely worsens. So maybe we have a higher demand dose ratio as compared to our continuous infusion to be a bit on the safer side if we're worried that someone might acutely become more altered or sedated. And so when we're thinking about titrating the dose, if you started a continuous infusion, you want to wait at least 24 hours before increasing the dose. And also, if someone is having acute worsening in their pain, or if it's uncontrolled, overall, we kind of utilize the demand dose in the cabs for that acute pain and make changes there if we need to before that 24-hour mark, because we're not going to see the effects of a change in the continuous infusion for about 4 to 6 hours anyway. So it doesn't make sense to kind of respond to acute pain with changes in the continuous infusion. So we look for demand doses and cabs first for that. If we do need to make changes, though, there's a few ways that you can think about increasing the dose. Sometimes you can look at the 24-hour amount, and similar to how we get our initial dosing, kind of take that 24-hour amount, take 80 to 100% of that dose, and make that our new continuous infusion, kind of folding it into the continuous infusion, and then also increasing the demand dose and the cab kind of in a ratio with that continuous infusion, the new dose. Or you can also go based off of the severity of pain. So if someone is having only partially controlled pain, it's somewhat working, but not all the way, maybe we think about increasing our dosing by 50%. Or if someone's pain is quite uncontrolled, maybe you say we're increasing it by 100%. So just kind of taking things like the morphine 2 milligrams per hour with 1 as a demand and 4 as a cab, and increasing that by 100% to 4, 2, and 8. And then when we're thinking about transitioning to an oral regimen, so for palliative care, we're oftentimes moving back to someone's home regimen or a new increased dosage based off maybe progression of disease. But for someone who's on a PCA for an acute issue that is resolving, you can think about starting to titrate down the PCA when you're seeing that the continuous infusion is greater than 50% of the total daily dose, meaning that they're not pushing the demand dose as much, that the majority is coming now from their continuous infusion. So theoretically, that means their pain is better controlled. And so we would start to titrate down at that time. For patients with chronic pain who are going on to a PO regimen, and we start to think about making this change once we have good pain control and when we don't expect that it's immediately we don't anticipate it worsening again. So to come up with this regimen, we take the total daily dose, we convert it into a PO opioid, and then take about 66% of that total daily dose to be our long-acting portion. And then typically we're going to divide that further into BID dosing. For the short-acting component, we're going to take 10% of the long-acting dosage before we made it BID and use that 10% as our Q4 to 6 hour PRN. And then thinking about kind of the timing of how to actually make that transition, you can kind of do it based off of the patient themselves and what you think their pain level is and how you think they'll do. So if someone is on a continuous infusion, you can give them the first dose of the long-acting PO medication and then stop the continuous infusion about 2 to 4 hours later to give the long-acting time to start working. If it's a bigger transition or you're a bit worried about pain control, you could also leave them either a backup IV clinician bolus or IV dose, or if you want to go even more slowly, you can leave the demand doses on for a day before pulling it off. And for people without a continuous infusion, it's the same process where you might leave them kind of an IV backup for a day while they transition to that PO regimen. And those are my references. Thank you so much.
Hi, my name is Molly Bewald, and I'm a palliative care physician at Mount Sinai Hospital in New York. And this is Methadone for Palliative Care Providers 2024. I have nothing to disclose. One thing that I want to point out before we jump into the meat of this presentation is that how we prescribe methadone for analgesia in palliative care changed in a really big way in 2019. So if you trained prior to that, this may look really different than what you're used to. Before 2019, people were doing it in a lot of really wildly different ways. Consensus guidelines were published by Lynn McPherson and others in Journal of Pain and Symptom Management in 2019. The citation is down here. And two of the big practice changes that are recommended in these guidelines are a change in how methadone dose is calculated based on a patient's prior opioid use, and new guidelines about EKG monitoring for a patient based on their goals of care. And the big point here is that the doses most people are using now are very, very conservative compared to what was being done before 2019. So fast forward to 2024, what's new in methadone in palliative care? There's a lot of interest right now in prescribing low-dose methadone and using methadone as an adjuvant analgesic alongside other opioids. There are small studies about doing this, but not enough data to make big conclusions, so look out for that coming down the road in the next few years. There's also a lot of interest right now in using methadone as a first-line opioid therapy for cancer pain, so I'd be on the lookout for more in that area as well. So what makes methadone so special that it gets its own special session? One really special thing about methadone is that it acts on multiple types of receptors. At the mu opioid receptor, it's an agonist similar to the other opioids that you think of. And then it also has some function at the NMDA receptor as an antagonist, similar to what ketamine does. Although there's some controversy in our field about how much this is actually happening at the small doses that we typically use. Because it acts in different ways on different receptors, its effects are really different than other opioids, and the conversion from other opioids to methadone is not linear, which can be really confusing. Another very special and strange thing about methadone is that the half-life is enormously variable in different people, between 5 and 130 hours. I don't know of any other medications that have such a big range in their half-life. This is part of the reason that we treat it so carefully and wait so long between dose increases. If you think about time to steady state, this is typically between 5 and 6 half-lives. So this means that the range of time to steady state for the individual you're taking care of is a huge range. Another interesting thing about methadone is that you see it prescribed daily every 24 hours for the treatment of opioid use disorder. It works to block cravings for more than 24 hours. But the duration of analgesia is about 8 hours for most patients. So you'll see that for pain, we prescribe it differently. We typically prescribe it every 8 hours, although you can prescribe it every 12 or every 6, depending on the situation. In terms of objectives for this part of the session, at the end of this, I want you to feel comfortable selecting candidates for methadone therapy based on their comorbidities and psychosocial issues, be able to calculate a starting dose of methadone based on a patient's prior opioid use, and to choose a plan for cardiac monitoring based on a patient's prognosis and goals of care. In terms of topics, we're going to go through selection, handling comorbid conditions, medication interactions, dosing and conversions, routes of administration, how to handle methadone maintenance therapy, and EKG guidelines. Okay. So how to pick potentially appropriate patients. For a patient to be appropriate to use methadone to treat their pain in a palliative care setting, you typically want to pick a patient with moderate, severe, or refractory pain. It can be appropriate in someone who has a morphine allergy. We'll talk more about this, but someone with kidney impairment, that might be a good choice. Someone where you need a long-acting opioid, including a long-acting opioid that can go through a PEG tube, which is not all long-acting opioids, because methadone is inherently long-acting. It's not the pill formulation that makes it long-acting. Someone with a high opioid tolerance might be a good pick. And there's some controversy about this, as I mentioned before, but someone with neuropathic pain, methadone might be a good selection for them, although there's controversy about how much methadone is acting at the NMDA receptors. Potentially inappropriate patients. So you really want to think about safety with methadone. So someone who lives alone without a responsible caregiver might not be a good fit. Someone undergoing a transition of care where on the receiving end there might not be a practitioner who feels comfortable prescribing or titrating methadone, probably not a good idea. Someone with QTC prolongation, structural heart disease, or other medical risk factors, and we'll talk a lot more about these. Someone with sleep apnea. Someone where the prognosis is shorter than the time to steady state. So somebody with a prognosis less than a week, probably not the right pick. And someone with a history of opioid non-adherence or substance misuse. And I highlight the opioid non-adherence because for us to safely prescribe methadone, we really need to be so confident that the patient is going to take the pills as prescribed, pick up the phone if you call them to check in on them, and show up to appointments so that you can really be safe with methadone prescribing. So methadone and comorbid illness. Given that by definition in palliative care, the patients we're caring for have serious illness, let's talk about how to handle some of those serious illnesses when we're prescribing methadone. Let's start with kidney disease. Methadone is mainly metabolized in the liver, and inactive metabolites are excreted in urine and feces. So the kidneys don't have a big role to play in clearance. This makes methadone a really useful opioid to consider for patients with renal impairment, including those on dialysis. If someone does have severe renal disease, it's recommended to be cautious with dosing and dose increases. So start low, go slow. And of note, only 1% of serum methadone is cleared by dialysis. Let's talk about liver disease next. So an important characteristic of methadone is that it has a high bioavailability, meaning that of the methadone you ingest, for most people, between 70 and 80% of it will enter the circulation. And it has minimal first pass clearance, which means that the liver doesn't remove very much of it before it hits the circulation. Metabolism does depend on the cytochrome P450 system in the liver. Therefore, metabolism is decreased in cirrhotic patients. The authors of the guidelines suggest avoiding methadone for a patient with end-stage liver disease and being conservative with your dose and titration schedule in any patient with liver dysfunction. For these patients, it might take as long as 2 weeks to reach steady state, so you again want to start low and go slow with dose increases. What about a patient with substance use disorder? In an ideal world, you would be able to co-manage with an addiction specialist, although the ability to do this depends on where you're practicing. And if a patient is actively using other illicit substances, the authors of the consensus paper consider this a contraindication to starting methadone for pain for safety reasons and risk of overdose. What about sleep apnea? Methadone itself is associated with sleep-disordered breathing. And in a study of patients on chronic methadone, about a third were found to have sleep apnea. And benzodiazepines have an additive effect. There's no specific guidelines for how to handle this, but if a patient has sleep apnea and you can use an alternate medication, you might want to consider doing that. And for these patients, you definitely want to try to avoid mixing methadone and benzodiazepine, unless there's a really clear benefit for doing that. We think a lot about methadone and QTC prolongation. So methadone inhibits expression of potassium channels, which inhibits repolarization. So we worry about QTC prolongation leading to arrhythmias and potentially death. If a patient's QTC is between 450 and 500 milliseconds, you could consider alternatives and talk about risk and benefit with your patient. If it's greater than 500 milliseconds, we generally avoid it. Of note, the effect is reversible when you stop methadone because it doesn't physically change the myocardium. This is a cardiovascular disease. Heart failure in and of itself is a risk factor for QT prolongation, and CAD and arrhythmias are risk factors for opioid-related death. It's reasonable in a population with heart disease, if goals are not purely comfort focused, to consider close EKG monitoring, which leads me to the guidelines for EKGs. When should we get an EKG for a patient on methadone? The authors of the white paper divide patients into three, they say, levels of vigilance based on a patient's goals of care and whether methadone is being used as a first-line or second-line treatment. The highest level of vigilance is for patients undergoing curative or life-prolonging treatment, where methadone is being used as a first-line treatment. For these patients, you follow the American Pain Society guidelines, which are to get a baseline EKG if the person has risk factors. What kinds of risk factors? Risk factors include electrolyte disturbances, liver dysfunction, structural heart disease, and things that make you concerned about a patient's QT, like being on other QTc prolonging medications or having a known genetic predisposition. When do you get a follow-up EKG for patients in the high level of vigilance category? You want to do this 2 to 4 weeks after starting methadone, so knowing they're at steady state, and then repeat it once your total daily dose hits 30 milligrams, and repeat again when your total daily dose hits 100 milligrams. Let's move down to the bottom of the table. If someone has purely comfort-focused goals, EKGs are not routinely recommended unless there's a compelling indication of some kind. It's the middle of the chart where things get a little bit confusing. Here we have patients that you're handling with a moderate level of vigilance who either have life-prolonging goals where methadone is a second-line treatment or comfort-focused goals where methadone is being used first line. I think basically this is a group of patients who are not clearly in either of the extreme groups. Here, the recommendation is to discuss risks and benefits with your patient and not routinely get EKGs. What I want you to remember from this slide is to get a baseline EKG for a patient with life-prolonging goals and then repeat 2 to 4 weeks after starting. For medication interactions, there are so many medications that interact with methadone that it's hard to keep track of them. One high-yield way to remember them is to ask about the 3 A's. These are 3 groups that account for a high percentage of interactions. The big 3 are amiodarone, anti-infectives like Cipro, ketoconazole, erythromycin, and antidepressants like sertraline, paroxetine, and fluoxetine. These are all enzyme inhibitors, meaning that they slow down methadone metabolism, leading to a higher serum level of methadone. Dr. McPherson suggests decreasing your calculated methadone regimen by 25% if your patient is on a medication known to be an inhibitor. And when you're thinking about interactions, it's important to keep in mind medications that a patient might be starting or stopping while they're already on methadone and monitoring those closely. How to start methadone? Let's get to the exciting part and talk about how to actually work with methadone. In my view, this dosing table is the biggest change that happened when the new guidelines came out. There used to be 6 different ways of converting depending on the opioid dose a patient had been on. I love the simplicity of this table. There are 3 conversions, and even better, one of them is no conversion, so you don't even have to do math. Let's go through these. The first column on the left is opioid dose per 24 hours in oral morphine equivalents. This is divided into opioid naive, which includes patients taking up to 60 milligrams of oral morphine per day. Then there's the middle, people on 60 to 199 milligrams of oral morphine, and they are less than 65 years old. And then the most conservative category is for people on higher dose opioids, so taking more than 200 milligrams of oral morphine a day, or they're 65 years old, which automatically puts you into this conversion. The middle column here shows the actual conversion. So you can see that if someone's in the top row, opioid naive, or taking less than 60 milligrams, there's no conversion. You just start low dose methadone at a maximum of 7.5 milligrams in 24 hours. So examples of doses you might prescribe here are 1 milligram PO every 12 hours if you're being very conservative, or 2.5 milligrams every 8 hours if you're being a little bit less conservative. In the middle category, this is patients younger than 65 who are taking a moderate amount of oral morphine equivalents. You divide by 10 to get your 24-hour methadone dose. And an example start dose that you might calculate here could be 5 milligrams PO every 8 hours. And then for patients on more than 200 milligrams of oral morphine equivalent per day, or those who are older than 65 in this middle category, you divide by 20 to get your methadone dose. And of note, regardless of what number you calculate here, it is never recommended to start with more than 40 milligrams per 24-hour period. An example start dose that you might get here would be 10 milligrams PO every 8 hours. There are many different methods for converting off of one opioid and onto methadone. This is called the Edmonton method. And if you're interested in learning additional methods, please refer to the article. We've got 4 days represented here. Day 0 represents the day before you start methadone, and day 1 is your first day of methadone. You've got your scheduled opioid here. So generally your long-acting medication, your scheduled medication, your continuous infusion. Then you've got your methadone dose, and then you have a short-acting PRN. On day 0, the patient is on 100% of their original opioid because you haven't made any changes yet. They aren't on methadone yet, and they typically have a PRN opioid. On day 1 of the conversion, we reduce the scheduled opioid by 30 to 50%, start the full methadone dose, and continue the PRN as is. On day 2, we cut the scheduled opioid by an additional 30 to 50%, continue the same methadone dose, and continue the same PRN. And then on day 3, you fully discontinue the scheduled opioid if it wasn't already discontinued, continue the same methadone and same PRN. This is an important table and takes some practice to get used to. When I'm starting a patient on methadone, I typically draw out this table to help myself organize the conversion. What about converting from oral methadone to IV and back again? From oral to IV, it's a 2-to-1 ratio, so just cut the dose in half. This is conservative given methadone's good oral bioavailability. From IV to oral, it's not a direct conversion back, again being conservative. Just multiply by 1.3. And from oral methadone to oral morphine, a very conservative conversion is 1 to 3. These strange nonlinear conversions have to do with the range in bioavailability and the fact that methadone acts on the mu-opioid receptor and NMDA receptor, so it functions differently than other opioids. The action at the NMDA receptor is thought to prevent central sensitization to opioids and reduce opioid tolerance, which means that the higher the dose of original opioid the patient is on, the more potent methadone is potentially going to be for that patient. What about increasing the dose? We typically wait between 5 and 7 days before doing a dose increase because we want to make sure that we've reached steady state. One of the wildest things, again, about methadone is the half-life. It ranges in different people in a really wide way, but on average is about 35 hours. And while a single dose of methadone provides analgesia for an average of 4 to 8 hours, it takes days to reach steady state and full analgesia from a given dosing schedule. So once you've waited your 5 to 7 days, it's recommended to increase by no more than 5 milligrams per 24 hours for people on less than 40 milligrams of methadone. And once you've hit a dose of 40 milligrams or more, you can increase by a maximum of 10 milligrams at a time. This is another big change from before these guidelines came out. So if you see a colleague doing wild increases beyond this, remind them about the new guidelines. There are 3 main routes of administration. The smallest tablet is 5 milligrams and can be broken in half, so you can give 2.5 milligrams. It also comes in 10 milligram and 40 milligram increments, but the 40 milligram increment is typically only used for methadone maintenance treatment. An oral solution exists, and there's IV methadone, which contains a preservative called chlorobutanol that independently prolongs the QT, so use it with caution. And methadone can be given subcutaneously up to 3 milliliters per hour. What do you do when a patient is on methadone maintenance therapy already? Of note, the maintenance dose is not typically listed in prescription monitoring programs. If a patient plans to continue with their methadone maintenance program, some providers recommend ignoring the treatment program dose and prescribing for analgesia as you would for any other patient, with the knowledge that the patient is probably going to be somewhat tolerant and might need their analgesic dose up-titrated. For a patient who is too sick to return to their maintenance program, for instance, someone who's been enrolling in hospice, in some situations you might take the methadone maintenance treatment dose that they had been prescribed, divide it by 3 to dose every 8 hours, and titrate up as needed. It's important to make sure that you're documenting your rationale clearly and that methadone is not being used for opioid use disorder anymore, but now being used for pain. Let's do a practice problem. So this is Miss A. She's a 50-year-old woman with metastatic cancer on 60 milligrams of long-acting morphine every 12 hours and 15 milligrams of immediate release morphine every 4 hours PRN. She has taken no PRNs in the last week. So her oral morphine equivalent in 24 hours is 120 milligrams, 60 plus 60. So first, let's look at our conversion table. She's taking a total of 120 milligrams of PO morphine in 24 hours. So we go to the middle box in orange. She's in this category. And importantly, she's less than 65 years old. If this patient were 66 years old, it would automatically bump her down to the last category. So we're going to do our conversion. We're going to take her 120 milligrams of long-acting morphine, divide by 10 because of the 10-to-1 conversion, and this gives us 12 milligrams of PO methadone in 24 hours. So examples of start doses that you could use here are 2.5 milligrams PO every 8 hours, or 5 milligrams, 2.5 milligrams, 5 milligrams dosed every 8 hours. This table shows how to convert a patient from their current opioid onto methadone. Remember that day 0 is the situation before you started methadone, and day 1 is your first day of methadone. So in this case, we just put in what our patient is already on. She's taking MS content 60 milligrams twice a day. And then her PRN is immediate release morphine, 15 milligrams, Q4 hours PRN. And she's not on any methadone yet because it's day 0 and we haven't started it yet. On day 1, we're going to decrease the scheduled opioid by 30 to 50%. In this case, the amount you decrease is limited by the available sizes that MS content comes in and you can't chop it. So we're going to cut her to the next available dose, which is a 50% decrease to 30 milligrams BID. We're going to start our full calculated dose of methadone. And for simplicity's sake, we're going to use 2.5 milligrams PO every 8 hours, which is a little bit conservative. And then we're going to keep the PRN the same throughout. On day 2, we're going to cut by a further 30 to 50%. In this case, you're again limited by the sizes of MS content that exists. So let's cut her to 15 milligrams BID. We're going to keep the methadone dose the same, keep the PRN the same. And then on day 3, we're going to stop the MS content completely, keep the methadone the same, and keep the PRN the same. So in summary, methadone is a powerful tool for pain management and palliative care. You want to be careful with your starting doses and slowly titrate it. And you want to be thoughtful about a patient's medical history and other medications when you're dosing it. And I'm going to stop there.